I'm Dr Louise Newson. I'm a GP and menopause specialist, and I'm also the founder of the Newson Health Menopause and Wellbeing Centre here in Stratford-upon-Avon. I'm also the founder of the free Balance app. Each week on my podcast, join me and my special guests where we discuss all things perimenopause and menopause. We talk about the latest research, bust myths on menopause symptoms and treatments, and often share moving and always inspirational personal stories. This podcast is brought to you by the Newson Health Group, which has clinics across the UK dedicated to providing individualized perimenopause and menopause care for all women. So today is the anniversary, actually, of something that's very exciting to me and us. So it's 8 years since the NICE menopause guidance came out. So we thought we'd have a little conversation about it and also welcome you to Katy Jackson, who's our Chief Clinical Officer and also our Operations Director, who's recently joined the Newson Health Group. So welcome, Katy.
Thank you, Louise. It's great to be here.
So before we get started about our anniversary celebrations, can you just explain a bit about your background and what you've done before you started working with us?
Yeah, so I'm actually a pharmacist by trade, still on the register. I was chief pharmacist for many years in clinical commissioning groups, more recently Integrated Care Board. And I've maintained my registration. I've been working on a weekend every so often as a community pharmacist, so to keep my knowledge up to date. My career developed from being a pharmacist to being a director of commissioning, working across, again, clinical commissioning groups, commissioning services, working across patient pathways with all of our providers. That includes GPs and hospitals. And obviously everything that we're involved with has always included pathways, prescribing. So it's been a really good use of my skills. And during COVID, I actually was seconded into a large teaching hospital as the chief operating officer as well. So got lots of experience in managing services during particularly difficult and challenging times.
Great. So NICE guidance came out 8 years ago, and it came out at a time when I was doing some extra training to become a menopause specialist. And on the second day of a 2-day course was the launch of the NICE menopause guidance in November 2015. And it was the first time that there'd ever been any national guidance actually in the menopause. And for me, it was really exciting. And actually, when I read them, I thought, oh, they're quite simplistic. They're quite easy to understand. And wow, this is going to make a difference to women's health. Sadly, that's not quite happened. But before we talk about the menopause guidance, Katy, can you just explain what NICE is and what it stands for and what it does?
So NICE is the National Institute of Clinical Healthcare and Excellence. And what it does is it produces guidelines for disease areas. And that would include the whole patient pathway. And at the point of development, they use a group of stakeholders, different experts that are picked from different walks of life, but have an interest or work within a particular therapy area. They look at the evidence available to them at that time, and that is used to develop a pathway. The pathway is intended to act as a guide. The guidelines, it's not mandatory to apply the guidelines, and that's actually specifically stated in NICE guidance. But clinicians, service developers are expected to take on board the guidelines whenever they're developing services or providing advice. The thing about the guidance is obviously at the point of publication, and these NICE guidance were published many years ago, they're almost out of date as soon as they're published. So it's really important to use that as context, that things happen in the interim. I think they're really useful for GPs who've never experienced or haven't had education and training in menopause treatment, and they're good to use as sort of a framework. But I think it's important to look at most up-to-date evidence alongside, and it's also really important to make sure that each patient, as you would with any other disease area, is seen as an individual. and circumstances are, very individual. So one size doesn't fit all, and one particular treatment pathway or recommendation is not necessarily right for two people sitting side by side. It could be very different.
Absolutely, they are just a guide at the end of the day, but really important. But actually, when I was a GP, guidelines would come out all the time, and there's lots and lots of nice guidance in lots and lots of different disease areas, and it's impossible actually to keep up to date with them. You can read the summary, but actually when you go into them, there's a lot of information, there's a lot of references as well. And I had the real privilege, when the guidance came out, I was working with the Royal College of GPs, and they had this thing called Essential Knowledge Updates, EKUs. And what they were was actually a summary of the NICE guidance. So I did it for lots of NICE guidance, but I was asked to do the menopause one. And there's no better way of knowing a guidance than writing and talking about it. So I did a whole PowerPoint presentation about it. I was recorded talking about it, but I also summarized it as well. And that way, not only did I read it, but I also read all the references that were associated with it. So I do have a super knowledge of the guidance, which is really important.
Yeah.
But as you say, it's now 8 years old. So evidence has changed, of course. But there's some really good take-home sort of messages in the guidance that are still very relevant to today. And one of them, obviously, is what the menopause is. And we know that the menopause affects all women. What they do talk a lot about are the vasomotor symptoms, vaginal dryness, and they don't talk as much as we know about the other aspects of the menopause, which is a shame, but they still do talk about the anxiety, the low mood. And that is important because they're very clear, aren't they, that antidepressants should not be used first line for the low mood associated with the menopause. And actually, when I read that sentence 8 years ago, I thought, but most of my friends have been offered or given antidepressants. And I did an audit then of our patients, and then when I opened my clinic, I asked every patient whether they'd been offered or given antidepressants, and then 66%, so 2/3 of them had. Whereas now we did a similar audit recently, and it had gone down to about 33%, so less.
Yeah.
But it's still a significant number of women I hear a lot on social media, who are offered or given antidepressants. So that's something that, again, hasn't changed, has it? We shouldn't be giving antidepressants for the low mood. And obviously, some women do have clinical depression and are menopausal, so they might need antidepressants, but it shouldn't be given as a first-line treatment unless we think someone has got a psychiatric illness or clinical depression. And then they also state that HRT is first-line treatment, which it still is, isn't it, Katy?
Yeah, it is. It's still first-line treatment. I think it's important to know that, I think there's more and more around HRT, the risks, the benefits, and as long as each individual patient has a tailored sort of decision-making consultation with their clinician, HRT is a really good option. But if it's not right for them, there are other things as well, like lifestyle, diet, advice. I know some people don't particularly want to go on HRT because they may be concerned. I think we can myth bust quite a lot of things around that area. But I think HRT is still the first choice. And I think that most GPs that I've worked with over the years, that is one thing that they would initiate. And I think most of them feel comfortable initiating it. In most patients, just some of them lack confidence around monitoring and dose titration.
Yeah, so it's very clear HRT is the first line treatment because we're treating the underlying cause of the symptoms and what the menopause is, which is a hormone deficiency. So HRT is first line, which is what they say. They also say about diagnosis of the menopause, and they're very clear, actually. If women are over the age of 45, they don't need blood tests to diagnose the menopause. Where the guidance, and again, it's just a guidance, can be sometimes confusing because they say if women are between 40 and 45, a blood test may be useful. So that also shows it may not be useful. But it does state that if a woman are under the age of 40, then an FSH level should be done at least twice, actually. But the FSH, the follicle stimulating hormone, is something our brain produces if our hormone levels are low. But during the perimenopause and sometimes early in the menopause, actually, that level can be normal or it can be low. And certainly I've seen quite a few menopausal women who have had their FSH suppressed by certain drugs, such as quetiapine, which is an antipsychotic drug. It switches off the axis so you have less FSH, but it will also suppress estrogen and testosterone and progesterone production. So the guidelines, although they state FSH should be done, and I used to do it religiously on all my patients, and then I found a lot of women were having a normal FSH level, but they were still telling me that they were having night sweats, they were having poor sleep, they were having joint pains, they were having headaches, and actually they hadn't had periods for many months. So in medicine, you have to treat the patient more than the number. And so with my clinical experience and actually common sense, we know that FSH isn't 100% sensitive or specific for the menopause or perimenopause, even in young women. So that's an area that, and I know people like the International Menopause Society are reviewing that criteria, because in clinical practice, it's not just about a blood test. So that's one area. The other area that I thought was really important when it came out, there's quite a lot dedicated to POI, premature ovarian insufficiency. And actually, when I was a junior doctor, I was taught if a woman doesn't have periods, Louise, just make sure she's not pregnant and then don't worry about it. And I didn't worry about it because I didn't really know women could be so young when they became menopausal. I wasn't expecting women in their teens, 20s, 30s to be menopausal. It just wasn't something that was on my radar. So when this came out and they were saying 1% of women have POI, premature ovarian insufficiency, and actually the health risks are more for these younger women, and we should be considering HRT first line for symptoms, but also to reduce risk of diseases, it made me really read more about this topic and how important it is that young women are not denied hormones for the wrong reasons. And for young women, there aren't risks in the same as there might be with some types of HRT. So for the majority of women who are young, really should be offered. And certainly women who are young, who have their ovaries removed, should really be spoken to and prescribed hormones before they leave hospital, unless there's a reason why they can't have hormones. But that still isn't being done enough, is it?
No, and I think that's where when you deviate from your bog standard lady over 50, periods have stopped, maybe a bit of HRT might help with the symptoms. When you deviate from that, I think that's where there's a massive lack of education and understanding from primary care clinicians. You will have some that have got a special interest that, have done a lot of advanced training, but I think that's where the guidelines need to be a lot clearer.
Absolutely. So it's about, some people say 1%, but recently more people have said 3% of women under the age of 40 have early menopause. And in some areas it will be higher. So, for example, women living with HIV, we know a lot higher incidence of early menopause in those women. So we need to be on hyper alert, actually, for women who are young. Really, really important. The other area that it discusses in some detail is vaginal symptoms, actually. So genitourinary syndrome of the menopause, which includes vaginal dryness, soreness, discomfort, irritation, and urinary symptoms. That's also spoken about. So vaginal hormones are different to HRT. And it also says how safe they are and effective. And the majority of women will actually have those symptoms. Yet a very small, when I've recently looked at the recent prescribing data, and HRT prescribing's increased, but vaginal hormones are still vanishingly low, actually, compared to the huge incidence. And that's certainly something that's worth exploring as well, isn't it?
It really is. And the number of ladies that end up going to their GPs complaining of being uncomfortable, ending up being prescribed sometimes antibiotics or cystitis treatments or even thrush treatment unnecessarily, when actually vaginal estrogen has been shown to be really beneficial. So I think, again, this is an education gap. And that's why these guidelines need to be regularly updated.
Yeah, absolutely. So, and then the other area it talks about is obviously there's benefits of HRT, and we need to remember that there are benefits. We've already said it's first-line treatment for symptoms, but actually the NICE guidance also states, and it's still right now, that HRT can reduce the risk of fragility fractures. So these are low-impact fractures, usually as a result of osteoporosis when the bones become thinner. And we know around 1 in 2 women over the age of 50 develop osteoporosis, 1 in 3 develop osteoporotic hip fracture. So really important when we're looking at reducing disease. So they do talk about fragility fractures. When they talk about heart disease, they're a bit sort of sitting on the fence and say it may not increase risk of heart disease. But actually since that time, we've got better data showing that HRT, certainly started within 10 years of the menopause, reduces incidence of cardiovascular disease. And then the risks bit. Now, a lot of people are told a risk of clot, stroke. Well, actually, there is a risk of clot and probably stroke with the older types of tablet estrogen with synthetic progesterone. So, but they do say that in NICE as well, that the transdermal through the skin preparations don't have this risk. And most of us prescribe the through the skin preparations first line. So that's an easy benefit risk sort of discussion. The other area that they've got a lot of information with quite complicated tables in actually is about the risk of breast cancer. But actually, there's a couple of things I think are important here. One is that this is all about older types of hormones that we don't usually prescribe. And secondly, the data from the WHI, the Women's Health Initiative study, which is where these tables are from, has been re-analysed, if you like, since those tables produced. And what they have shown is that women taking estrogen actually have a 23% lower risk of developing breast cancer and a 40% lower risk of dying from breast cancer. The synthetic progestogens, this increased risk isn't statistically significant. And so frustratingly, the guidance still say we should be considering HRT for the lowest dose, shortest length of time. But actually there isn't any evidence to say that when we look at the body identical natural hormones, is there?
No, and I think this is another, I talked about myth busting, that in the last 10 years, for example, things have changed dramatically. We've got more data. I think there is an urgent need to update the risks, the risk narrative around HRT. And I think that this is all part of good education for GPs, but also for patients. They need to make that informed decision about what treatment they're going on. If they've got questions, they need time in the consultation to have things explained to them, because everybody's read things in papers or spoken to older relatives that have had concerns in the past who are sort of regurgitating old sort of myths around dangers of HRT. So I think, again, it's a huge education opportunity, and I do hope that NICE makes those things really clear, because it will help GPs, pharmacists, nurses, educated patients, and get people on a drug that has got long-term benefits. I mean, the fragility fracture is so important. One of the things I saw when I worked in the acute sector is the number of ladies who had osteoporosis who would end up being admitted to hospital with a fractured neck of femur. So the burden on the NHS, if they've got a bit more of a long-termism form of approach, looking at public health widely, is quite significant. We've got an aging population. The bone protective effects are, underestimated.
Absolutely. And because it's mentioned in NICE, it should give people more confidence actually to think about that. And it is crucially important when osteoporosis is so common. So absolutely. The other area that it talks about quite a lot actually is about individualization of care. And it's really important. When I was a hospital doctor for many years, I don't think there was much individualization actually. The drug chart was always at the end of the bed. When I was a very junior doctor, my job literally was to write up drugs. And it was on a ward round, they'd say, right, start this patient on X drug. This is the dose, and you'd literally write it. Wouldn't even tell the patient what we were doing, wouldn't tell the patient what we were starting. And then they would have their take-home prescription and all these drugs on. And then the GPs would receive that and then transfer it onto the patient's record. Very barbaric medicine, actually, really very unidirectional. But actually, when I was a junior doctor, we didn't have Dr. Google, we didn't have the internet. So you just did it, and that was it. Things have really changed, and actually being an educator and a medical writer has really taught me the power of educating patients and enabling it to be a bi-directional consultation, if you like, and allowing ideas, concerns, expectations in the consultation to be there. And as a GP, I spent a lot of time exploring consultations and understanding what people want. And actually, the thing about the concerns bit is really important, because as a doctor, I might think wrongly, probably, that everybody's worried about this supposed risk of breast cancer. But actually, when I talk to women, most women are worried that they haven't been on it. They're worried about the risk of heart disease. They're worried about the risk of osteoporosis. And they're actually quite often worried that they might lose their job because they can't think properly, because they are so confused and their short-term memory is so bad, and they're not sleeping and whatever. And this is really, really important. And also they might be concerned because they've read or heard there's a risk of clot or there's a risk of something. And so unpicking that is where individualization is really important, isn't it? I think it's crucial the more that we see people and the more that we understand so much more.
Yeah, and women need time. So it may be that at the consultation, if they're seeing their GP, for example, they may feel a bit rushed. So and they may just be sent away with a patient information leaflet to make a decision about whether they want to start HRT or whatever approach they want to go down. So I think it's really important that women are given all of the facts, and together with their clinician, they can make a shared decision about what they want to do. And if they don't feel like they want to make that decision and get that first prescription at their first consultation, they can take that information away with them, or they can be directed to a repository of information. So, for example, the Balance app has got so many patient information resources to sort of help them. And I do think that it needs to be a very holistic approach. So, HRT is fabulous and, it works for everybody on the whole, but there are some people that don't want to take a drug. So they might decide that they're going to try and do sort of, diet, lifestyle. So again, they need to be told that actually that might not address all of their problems, like HRT might not address all of their problems, but they need to have all of the tools in front of them, and then they could decide which tools they want to pick up. And I think that it's having consistent information as well, because people get bombarded with info on the social media as well, and it can be confusing for the patient.
Yeah, absolutely. And there is it is commented and documented in the NICE guidance that people should have access to information in a way that they understand.
Yeah.
And that is crucially important. And it's also really important that women and patients understand these guidance, and they are written in a way that they are easy to understand, especially the summary, and we will link to that as well, because then it's easier to share the decision making and to talk things through. I was doing a presentation today for a big NHS trust, and two people asked me, actually, how can I improve the consultation with my GP? I have been turned away. I've been told I can't have HRT, yet I really want it. And that happens quite a lot to people that I talk to. And actually, often I say, why don't you ask them about which part of the NICE menopause guidance are they not happy with? Because a lot of times it's a knee-jerk reaction that the doctors might be worried because they've read something, or they've been educated in a way that's not up to date with the guidelines. Whereas I think even if the bare minimum that we all do as healthcare professionals is work out of the NICE menopause guidance that are now, as I've said, 8 years old, that's still acceptable, actually.
Yeah.
They're still fine. There's minutiae that, yes, I'd like a bit of more of the body identical hormones explained. Yes, I'd like the breast cancer risk looked at properly. And yes, I'd like more about symptoms. But actually, they are still fine. And certainly in our clinic, we use them as the building blocks for our consultations. They really are very sensible and pragmatic, and they're a great start. since the NICE guidance in the menopause have come out, actually, a couple of years ago, the shared decision-making guidance came out by NICE again. And that's the first time they'd produced the shared decision-making guidelines, aren't they? And I think they're really useful, not just in menopause, but in lots of aspects.
They really are. And it's like I was saying, it's like the patients need to be taking responsibility for the management of their condition. This is we spend more than, well, nearly, depending on how long you live, which hopefully would be a long time in the menopause. It's got to be the right decision for the patient. And for all disease areas, a shared decision-making approach needs to happen. And that's shared with the patient, the specialist, but also the GP, because a lot of patients will be going to their GP maybe after seeing a specialist and asking them to carry on prescribing, HRT, for example. Everybody needs to, again, it comes down to this clear communication.
Absolutely. And it is really important when we look at the shared decision-making guidelines, because they also say that the doctor and the patient might have different ideas and they might have different beliefs. And actually, if someone wants to refuse an evidence-based treatment, as long as they're reasonable and they consent and they understand, they're allowed to do that as long as they've got the knowledge and information. And so if I was a clinician that didn't agree that, say, for example, someone wanted HRT or didn't want it, I'm allowed to talk through, and we're allowed to have differencing in opinions. And I think that's really important for people to know that they are in control, if you like, more than perhaps they were before. But the other thing is, as a clinician, I'm very happy for people to get second opinions. I'm not there that I'm dictatorial and saying you must. I'm the only person that you can see. So there's lots of reasons why people might want to see a different clinician. It might be a personality thing, or it might be a management decision, or, like you say, it might be that I've run out of time and you haven't explored all the concerns and questions that you have, and you don't feel that you can make a decision in that consultation. It's absolutely fine as patients to say, actually, I'm going to go and see someone else, or I'm going to talk to someone else. And I think people should be encouraged to do that if they don't feel that they're getting the right help, advice and treatment that they were expecting in that consultation.
Yeah, and I think it's really important to signpost, even if you're a specialist in your area, to signpost to information, but also to other healthcare professionals, community pharmacists, for example. I've done locums for years, and we get lots of women that have come in when there have been HRT shortages, been quite obviously anxious, quite understandably, but want to know about alternatives, want to know how we're going to communicate to GPs about alternatives, want a bit more information about their patch. It might not be sticking, things like that maybe not have come up in their original appointment with their specialist or their GP. So it's important to use people like that as well. And it's ensuring that they're equipped with all the tools to self-manage their condition once they've had their consultation. They're still under the care of a menopause specialist or their GP or whoever it might be, but it's understanding who they can go to for additional advice, and not to feel pressurized into making a decision about starting a treatment straight away. That some people do take time. They want to go away. They want to read the evidence for themselves, and that's okay.
Absolutely. And the other thing on the NICE guidance, it doesn't talk in detail about dosing about HRT.
No.
It's about individualization. And I've spoken about it before, about different women need different doses, different types of HRT. And the final thing that we haven't mentioned, that I think is really, what I know is really important, is actually testosterone.
Yeah.
So testosterone is another hormone. It's a biologically active hormone that women produce in larger quantities when they're younger than estrogen. And it declines with age. So it's not really a menopause hormone. It's just an age-related hormone. But a lot of our testosterone does get produced by our ovaries. So when our ovaries don't work, or if they're removed in an operation, then of course our testosterone will be lower. But it does mention that we can consider testosterone as a treatment if women have reduced sexual desire despite taking HRT. And this is 8 years ago this was mentioned. And I remember giving a presentation for a Hot Topics course in Bristol not long after the guidance had come out. And there was a lot of pushback in the audience from other GPs to say, oh, but testosterone's dangerous. It's going to cause problems. It will cause side effects. It will this. And actually, I just started testosterone at that time and I was feeling amazing, so much better than I had done for about 10 years. And I said, well, actually, let's think about choice. Let's decide if women can have it, if they think. And as you know, everybody in the clinic here, we ask about libido. And if people do have reduced libido, despite being on HRT, we consider testosterone as a treatment, obviously looking very holistically for other reasons for reduced libido. But we do find, and our wealth and depth actually of clinical experience has shown us that women who take testosterone often find that their mood, their energy, their concentration, their stamina, their sleep, their muscle and joint pains improve. And we're not just the only clinic in the world that have noticed that. And when you look at the biological effects of hormones, especially in our brains, it's no surprise because it works in lots of areas of our brain. It works as a neurotransmitter. It works with other neurotransmitters. And so actually we know that the NICE guidance are going to be updated. And one of the recommendations is that there's more research done in the area of testosterone, especially in the non-libido improving effects of testosterone. But it is mentioned, and we know that about 25% of menopausal women will have HSDD, so hypoactive sexual desire disorder, which basically means your libido is not very good and doesn't improve. So even if it was only 25% of women that were offered testosterone, it's a significant number, but we know it's a real struggle to get testosterone, isn't it?
It is. I mean, there will be areas where it's actually on the formulary because it's in the NICE guidance, which is fabulous. A lot of people think of it as the missing piece of the jigsaw in terms of the HRT treatment. The formulary is a list of drugs that NHS trusts are allowed to prescribe, and they reference the NICE guidance on that. Obviously, there are a couple of products that are licensed, but they're licensed for men, so the doses are a lot. So it's basically licensed product for men, but used off-label. For women in much smaller doses. Obviously, there is a licensed product for women, which currently we can only get privately, which is an Australian brand. That is something that's quite popular as well. But a lot of women, what we're hearing is that they, if they're having struggles getting it from their NHS GP, they take the NICE guidance along with them. They print it out. So it's again about that informed decision. Sometimes the GPs won't know anything about it. So again, it's an education piece, but it's really, really good that NICE with their update are going to be doing more research in this area. For so many women, it is the missing piece.
Absolutely, and really important.
Yeah.
So that's been a great summary of the NICE menopause guidance, which is now 8 years old. Before I end, Katy, I just want to ask you 3 take-home tips, because I always do at the end of a podcast. So 3 reasons why women, but also healthcare professionals, should know about the NICE menopause guidance.
I think it will really help in them making the right decision for them around managing their menopause or their perimenopause. So having the NICE guidance is a really good, like you said, building block. It's very useful. So, you know, you can print a sort of patient-friendly version if you go on the NICE website. So that's really good. I think in terms of educating our clinicians and developing services, whether that's in the NHS or privately, having a really clear pathway that is accessible and relatable is something that will be really useful, not just to doctors, patients, but also people who are developing services, so more people can get access, whatever their financial status. Lots of people can't afford to go privately, so the NHS really does need to step up. And I think the other thing is understand that NICE guidance needs to probably be updated more regularly, I think, and maybe rather than every 8 years, we need more, because people do respect it. And having that continual improvement, looking at more research, keeping on top of that, and not leave it 8 years next time.
Perfect. Thank you ever so much. Thank you for your
time. Thank you.
You can find out more about Newson Health Group by visiting www.newsonhealth.co.uk. and you can download the free Balance app on the App Store or Google Play.